I will talk on some technical issues of lung screening, some of which will be very familiar, others may be slightly newer for you, and some issues may be not new, but misunderstood. Here are my disclosures, and what I say is my opinion. Lung cancer screening in the European Union is really getting into an acceleration phase. And this report basically gave two recommendations, namely that the screening programs need to be extended if there's a good harm to benefit ratio and good cost efficiency, and that means also lung cancer screening should be included in screening programs by the various countries. So it is a question of time till that actually will happen in the various European countries. We are fighting for it in the Netherlands. At the moment we are running against walls, but we hope that that will help us break down these walls. Now, one of the reasons why people are a little skeptical is radiation exposure. And many of you who are a little older know this landmark paper by David Brenner. He basically wrote an article in the New England Journal, which is considered God's paper. So in other words, if it's published there, it must be true. And it changed the way people looked at radiation dose, especially in the US, but also worldwide. Before that, radiation dose was not an issue. After that, it was the most important issue because, as he stated, about maximum 2% of all cancers in the United States might be attributable to CT scans. Now, there are lots of issues with this paper. I'm not going into it. But what is important to understand that at that point, a normal chest CT would take about 10 millisieverts and a low-dose chest CT 1 to 3 millisieverts, depending on where you were. Now, we're nowadays much lower, and you'll show you in a moment how that goes. Is it all rubbish? No, but because there's one area that we have to be careful of. If you look at the cancers that you induce by radiation, breast and stomach are mainly for the young people. Lung cancer, and we're screening for lung cancer, is important in the screening population. Basically, in the age range, let's say 40 to 70 years, it's the main dominant cancer induced by radiation. Now, what can we do as radiologists to reduce radiation exposure? All of you know you should use automatic exposure controls and lower MS. And the exposure controls are usually used by increasing your target noise, that gives you lower dose, or lower reference MAS in some other systems. Now, you all have now learned that you should use low KVP, because that really reduces the dose and makes everything better. That is true, but it's only true for contrast-enhanced scans. It is not true for non-contrast scans. And the reason for that is that the absorption by iodine goes up massively with low KEV. In other words, you get much more bang for the buck at low KEV. The absorption of soft tissue in CT numbers remains almost totally constant across the KV range, which means you get only the negative effects of low KEP, which basically means that the low energy photons get stuck in yourself if you're the one on the scanner table, and relatively less hit the detector. So the higher the KVP, the better. There's a little problem there, and that problem is that the lowest MA that your scanners will be able to provide is limited. So you can't go down to 0.05 MA. You'll probably end up at, let's say, 5 to 10 MA, which means once you hit that limit, AEC doesn't really work anymore. And in order to give less dose to the patient means you have to go down with your KVP, because at lower KVP, the same MAS gives you less dose. This is the real reason why in slim patients we're giving 100 kV even for non-contrast CT, because the dose goes down because the limit for the MAS is reached at the higher kV and you get relatively more dose. So if you have a good scanner, you can use an auto kV to make sure that you get the optimum situation in kV. But in principle, the bigger the patient, the higher the kV. Another thing that we will hear about in a moment is stronger beam filtration. Some vendors have thin filters, others have silver filters, and we'll hear a lot about that in a moment from Russell. And the advantage here is these filters remove exactly those photons you don't want to see. It's the relatively low kV photos that get stuck in the patient. So by removing those, it helps to contribute, keep those photons that contribute more to the patient dose, to the detector signal than to the patient dose. And finally, if your scanner has an APPA modulation, you should use it. That means that you give less dose in a AP direction than in a PA direction, because on the front you have the breasts and you have the thyroids. So if you can do that, you reduce the relative dose to the patient. That's basically what it is. You can see that if you use a tin or a silver beam, the spectrum shifts to the left, but you need a much more powerful tube because at the end there's less radiation that comes out of it. So the nominal MAS goes up despite the fact that the radiation dose for the patient goes down. Now, there's other ways of reducing radiation exposure. One is more efficient detectors, basically detectors that have thicker absorption material and less dead space between the detector elements, and detectors that have less electronic noise that you can do by better electronics. The more transistors, the less the electronic noise, or photon counting, which has no dead space and also has no electronic noise. But the absorption, also for electronic photon counting, is not 100%. It depends on the thickness of the material. So photon counting does solve the electronic noise issue, but it doesn't solve the absorption issue. And finally, image reconstruction. All of you hopefully use iterative reconstruction in its various forms, and in the future, deep learning reconstruction. Some of the vendors have it already available now, and I'll show you a few examples. And this is basically how it looks like. You have a filtered back projection, what we all used forever, until hybrid iterative reconstruction showed up, and you see a better image quality. And when you go to model-based and deep learning reconstruction, you see almost no perceivable improvement. If you look at it, you see a bit better image quality with the model-based iterative reconstruction. The lung itself looks a little bit more pixely. If you look at the mediastinum, the noise becomes best in the deep learning situation. It changes if you lower the dose even more. Then the differences become much more pronounced. Here's the same again in a coronal direction. Here's the example of what happens if you go for really low doses. And the classic areas where it's really difficult is close to the diaphragm, and actually in the recesses and at the lung top. And with these model-based iterative reconstructions and at a higher speed with the deep learning reconstructions, you avoid these problems and get very good image quality at a dose reduction of a factor 5 to 10 compared to what we used to have for low-dose CT. Here, the whole thing kind of magnified. Here, another example, hybrid iterative reconstruction, 1 millimeter slice, relatively low dose. You can see a ground glass, maybe a part solid nodule. If you go to a deep learning reconstruction, you can see that much more structure is available, and you get, for the same amount of dose, a much higher image quality. If you look at it in the big picture and compare it to the natural background radiation with a CT of the chest, we are now in the range, or actually for many of the scanners, well below the natural background radiation. At our institution, we're in the range of about 1 to 1.5 millisievert. If you go for low dose and ultra low dose, we are now in the range of a transatlantic flight to and fro from Europe to Japan. And the reason why that's the case is because we go by the polar route, and the polar route is especially radiation prone because we are not protected by the magnetic field of the Earth. That's something that you have to keep in mind. So, all right, sidestep. Radiation-induced cancers are not only depending on the CT acquisition, but the total dose. And that includes the scanogram and the total number of skinning exams. So, if you can optimize our workflows so that we have a minimum of follow-up for suspicious nodules, we also gain a little bit. Of course, it's not that much. And there are other areas like biopsy and staging where we again add dose to the patient. But again, in the big thing in the big picture, that's not that much. It's depending on the age, sex, of course. And one thing that we are underestimating is the genetic risk. So women with a BRCA mutation have a higher genetic risk for cancer induction, also lung cancer induction, on the basis of radiation. That's something that we do nothing with at the moment, but that's something that we should keep in the back of our minds. Now, the EU measurement, or the EU statement also said something about cost efficiency. I'm not going to look at the efficiency. We've heard about that, and we will hear about it tomorrow. I'll focus on the cost. Here's a little bit the efficiency, but anyway, you can see that if you do surgery, you get a lot of cost at the time of surgery and nothing else. While if you have to do chemo or immunotherapy, all the cost comes later on, and it can become really massive, especially when you live in the US. And compared to lung screening, the cost for saving one life is massively different. So it really makes sense to look in this direction. So if you look at the cost components, CT is not the only one. There are other components that we're usually neglecting, but they are things like the invitation, recruitment, and administration. Usually that's somewhere else in the system, but it has substantial costs. Smoking cessation, if you want to do it well, is adding a substantial amount of cost. And what I'm going to talk about is the low-dose CT exam. And here, the main factor is the speed at which you can get a patient through the scanner. It doesn't mean the speed of scanning itself, but getting them in and out. And the hourly cost is determined by the scanner costs, like depreciation, service, energy, and building, but also on the personnel, the radiographer, radiologist, and any type of support you need. And I've done some calculations. If I'm able to do, like, say, 4 exams per hour, you get a totally different result than if I'm able to do 10 exams per hour. And the costs actually go down massively by doing so. So speed becomes the massive component of what I need to charge for a CT. And just for your understanding, during the Nodule trial, we've optimized it quite a bit. We had 3 changing rooms draining into our CT room. We had only removed the metal objects, usually that's bras or belts, and we kept this table at the scanning height, and we had a little step that patients could kind of, or people, they're just normal adults, they can step on the table, lie down, and on we go. We have someone who kind of takes them from there, puts them on the scanner, and puts them back, and we have an interface that optimizes this. And the intuitive scanner interfaces are helpful. Canon has really worked on that. Super simple, and as much automation as possible. So automatic sequence from a scanogram to scanning, and we'll hear about 3D scanograms in a moment. There are now scanners, and Canon has one that has automatic landmark detection. So again, playing around with the scan range is no longer necessary. And finally, automated reconstruction and image routing are important. We've already heard about the image reconstruction, but the reading is another very important factor. If you can speed it up, that really helps. You've seen this just a moment ago, 3.5 minutes. If you let a radiologist do that, it's less than 1.5 minutes. So these workstations really help, but you have to keep in mind, if you want to stay focused, more than an hour is not a good idea. Finally, nodule optimization. You all know that we're looking at volumes, and a pixel on a CT, I'm not sure how you know, whether you know what the typical pixel size is. If you have 12x12 matrix, field of view of 350 millimeters, it's twice that, so 0.7 millimeter. And if you have a field of view of 500, that will be 1 millimeter. So it's not a really great resolution that we have for the pixels. And that means if I err just 1 pixel in either of those, it could look as if I have an 8.6 millimeter or a 9.0 millimeter, and they are basically almost identical despite the fact that it has grown. That's the reason why volumetry is much more sensitive, and this example shows it also. A diameter change of 0.4 millimeter is actually already a 20% volume change if you go from 80 cubes to 100. And for larger lesions here, a 2 millimeter change would mean 96%, almost a doubling of the volume. So volume is much more sensitive to change. And another example, this light blue area shows you lung RADS 4. And you can see for a nodule volume of 50 to 100, there were quite a few lung rats for. So in other words, lesions that they were measured much too big. And on the other hand, you can see that for the larger lesions, they are not really on exactly the axis. The variability is massive, and you can reduce that really substantially if you do volumetry. Reproducibility of nodule volumetry, most of them refer to Hester's paper. Hester Gittema had been working on that, and we were at that time forced by radiology to take all nodules that were in the image for this so-called coffee break experiment, in which patients go on the table, go off the table, are scanned twice. So you have the variability of the positioning, but the nodule obviously hasn't grown. So you can see what the inter-observer variability is, and it turned out to be very constantly 25%. Problem was there were many nodules in there that weren't segmented correctly because the software then wasn't that great. And this has not been published because they threw it out of our paper. This is what happened if you would have taken only correctly segmented nodules, which most of the modern softwares will do. And that's why it's so important that the software of the AI companies that you look at really allows you to adapt if it doesn't do the correct segmentation. The reproducibility defines how well you can determine a volume doubling time. And you get crazy things. Let's say you have a real volume doubling time of 250 days, and you have too much of a variability. You can get a volume doubling time of 150 days. Yeah, okay, that's a malignant one. But you could also get a volume doubling time of infinite, or actually a volume doubling time of 1,000 days. So the variability is behaving totally non-Gaussian for volume doubling times, and you get really crazy results. The crazy results become less crazy if you have a good reproducibility. We've done that now with a high-end CT and an ultra-high resolution CT scanner, and what you can see is that the confidence intervals go down quite substantially, and as you can also see, the relative percentages are, of course, diameter dependent. If you have a small nodule, the relative changes become bigger than for larger nodules. And the result is that in theory, you can now, with newer scanners, reduce the follow-up time to really come to a better estimation of whether something's malignant or not. And the better the scanner, the higher the resolution, the shorter that goes. Very nice Japanese paper that looked at ultra-high resolution CT to predict invasive adenocarcinoma. There's a relative trivial predictor, which is the size of the solid core. And there are various cutoffs in their paper. It's about 8 millimeter. But there's another one, which is the disruption of the air bronchiogram. And what you can see, if you look at this little bronchus here, you suddenly see that this thing becomes filled up. If you see that, that's a predictor of invasive adenocarcinoma. And for that, resolution obviously helps. So to summarize, essential technologies are on the workflow side, getting the right room. I haven't mentioned that here, but automation, a good interface, and if you can, in-room operation, which means that instead of having 2 people, you may only use 1 person who stays in the scanner room. For the scanner, very important, if you have it, use it. Deep learning reconstruction is a real game changer in image quality. Stronger pream filters help, low electronic noise or photon counting helps, and the high spatial resolution helps with the follow-up intervals and with the security of differentiating between benign and malignant. And with that, I thank you for your attention.